I thought today it might be a good opportunity to employ more of some of the things we're leveraging in adult cardiovascular trials or in clinical practice that might help us to understand how we best characterize the cardiovascular implications of Barth syndrome moving forward. So we'll speak very briefly on, so these are 5 types of genetically triggered or non-acquired sort of types of cardiomyopathies, so dilated hypertrophic left ventricular non-compaction, where I spend a lot of my research time, restrictive cardiomyopathy, and then arrhythmogenic cardiomyopathies. So a little bit of background. The majority of focus for many years, and this is still what we really do in pediatric cardiology, is isolated to systolic dysfunction. And in the adult world, we would refer to that as heart failure with reduced ejection fraction. And classically, that would be somewhere in LVF in the line of 40 or so, and some of that's debatable. But in the adult world, we're really starting to find more and more that about half of our heart failure admissions are really related more to what we would call this idea of HFpEF. And this is what would previously would have been termed or phrased diastolic dysfunction. It's a little more of a complicated discussion than I have time to explain, but heart failure with preserved ejection fraction is a real problem. And the difference between these two is significant because we have established therapies for number 1. We don't have effective therapies for number 2. So that's sort of a takeaway. So I'll spend a little bit of time talking about diagnostic strategies. And as everyone knows, echocardiography is what's most commonly employed both in children and adults. And obviously it's very portable, it's reasonably inexpensive, most people know how to interpret it. So there's crosstalk across centers, across countries, that sort of thing. And it has some opportunities. It gives you a chance to characterize myocardial size, the thickness of the LV, the RV to some extent, the atrial. And it gives you an idea of systolic function. There are some advanced imaging techniques, which you heard in some of the talks yesterday. It can be employed, things such as strain or tissue deformation, which give you local ideas of systolic squeeze and relaxation, the rate at which that happens. And then 3-dimensional imaging, which gives you more of a volumetric opportunity. And these may be helpful for the diagnosis of certain types of cardiomyopathies. So this would be an echocardiogram on someone with really end-stage dilated cardiomyopathy, so you can appreciate that they have a very dilated and adversely remodeled left ventricle. You can even see evidence of spontaneous echocontrast, indicating this patient may have been at a higher risk of a stroke because of thrombus formation. And then you can leverage things like 2-dimensional imaging to diagnose left ventricular non-compaction, which is something that obviously we deal with in the setting of Barth syndrome. And you can appreciate here very nice pictures of these deep trabeculations and recesses, which is how we diagnose morphologically. We would diagnose LV and C. And then once again, just an echocardiogram of that similar view. You can appreciate this is how we would potentially diagnose a phenotype, a cardiomyopathy phenotype. But there are some limitations to echocardiography. Echo can also evaluate diastolic function, as we were talking about, so this idea of how do we get at HFpEF. There are inherent limitations, and it's a typical part of adult echocardiographic examination. So if you were to get a report from an adult echo lab, you would have diastolic indices on that report, and they may tell you patients have grade 1 diastolic dysfunction. In pediatric examinations, I can tell you the majority of centers in the United States do not report diastology. We have only recently started implementing that into our echocardiographic reports, and there's a fair amount of reasoning behind that. A lot of it is because there's not real uniform agreement on normative data for diastolic function by echocardiography in pediatric patients. But you can appreciate this is an area that's underexplored. This isn't something we take full advantage of when we manage these patients in clinical cardiology, because it really is an entity that hasn't been explored or described to any great degree in pediatric cardiovascular medicine. We talk about things like restrictive physiology and restrictive filling patterns, but no one really has delved into the idea of this idea of isolated, standalone heart failure with preserved ejection fraction. And as we've talked about, diastolic dysfunction can be assessed non-invasively. And there were some, this is by no means meant to be talked about or read to any great degree. This is purely just an opportunity. This came up yesterday in one of the discussions about looking at E waves and A waves and E to A ratios and that sort of things and some of the limitations. And I'll tell you that, and so one of the papers, the project we're working on with Zaza, that we've found some of these data that maybe there are some hints that diastolic function is abnormal, at least in some of the mouse models. But I can tell you all of these parameters that we measure, and you can appreciate on the far right are all the limitations. All of them have limitations, unfortunately. Many of those are volume dependent. Some of them are dependent on RV function. Other things that might implicate how we would non-invasively assess diastolic function. But it's an important thing, and the key is that it's non-invasive, right? To get real data, to get the sort of gold standard data requires an invasive approach in the form of cardiac catheterization, which obviously we would prefer not to do. So, but this idea of a preserved ejection fraction has important implications, and I think when we talk about our Barth syndrome population or any other cardiomyopathy population, as we get better at treating their systolic dysfunction, they're going to age. Hopefully, we'll continue to do a better and better job. You've heard from us and others in the past about employing standard heart failure therapies, which I'll allude to a little bit in the talk, but potentially offering things like mechanical circulatory support, ventricular assist devices, cardiac transplantation, all those things improving longevity. If you follow those patients long enough and you think about what some of the mechanistic problems are behind cardiomyopathy in the setting of Barth syndrome, it's very likely that the problems with the ability of the heart to relax are going to become more and more manifest. So you develop more changes in your extracellular space. So we talk a lot about the cardiomyocyte in these conferences, but that's only a small part of the picture when we talk about remodeling or when we see changes in the ventricle, the way that the heart relaxes, the way that the heart squeezes. And this is simply just to show you that in patients with preserved ejection fraction but evidence of heart failure, that their filling pressures are higher, even when this is at rest, so these solid lines are at rest, and with exercise, and these things become more dramatic with exercise. And you have to remember that there are a lot of patients, and we've seen this in some of the mouse data, which I thought was kind of interesting, is that maybe they don't have evidence of myocardial disease at rest, but when you stress them, this is provoked, right? This might be one of those mechanisms that we're under-leveraging, recognizing that non-invasive imaging in mice is a little bit more challenging to accrue some of those data I was talking about than it is in humans. And this is some of the complex pathophysiology of HFpEF, and ultimately, when we talk about HFpEF, I hope the takeaway is that diastolic dysfunction in and of itself is not a simple process. When you think about how the heart relaxes, many people think about diastolic dysfunction as sort of a bellows, like what you would do to blow air. And those bellows, for whatever reason, become a little stiff and just can't suck in air as well as they used to in the past. Diastolic function is not a passive process. The way that you empty the atria is actually very active. Your LV is sucking blood out of the left atrium. So when that happens, when that becomes compromised, your LA pressures have to increase to compensate. Your RV has to be functional. There are ventricular arterial coupling mechanisms that implicate diastolic dysfunction as well as systolic dysfunction. My point from all of this is simply that the way that we characterize myocardial disease or cardiomyopathy in Barth syndrome could probably be more robust. And these are some of the opportunities that I think we could take away. A little bit about cardiac MR. We leverage this modality very heavily at our institution. And I'll take you to the bottom slide, is that people don't really think about imaging as a biomarker. We spend a lot of time talking about biomarkers in the heart failure world, about BNPs and NT-proBNPs and ST2s and galectin-3s and all these different things. But imaging is a very powerful and robust biomarker. And when I talk to families about cardiac MR versus echo, I usually describe echo as sort of the black and white TV with the antenna. You know, that's kind of the image that you're getting. When we look at things like cardiac MR, it's more of like, this is sort of the 4K version of high definition TV. And the important thing is that if you take nothing away is that you can characterize the myocardium, okay? So echo gives me no idea about the integrity of the cardiomyocytes, gives me no idea about the extracellular space. And so when we talk about changes in heart muscle, and especially in the form of dilated cardiomyopathy, we get captivated by talking about ejection fractions over and over. You'll hear, or shortening fractions, right? That's what we talk about. We think we're making an important change. I can tell you as a clinical endpoint, the FDA will not accept changes in ejection fraction as efficacy for drug therapy or device therapy, okay? So what we really care about is the remodeling of the myocardium. So when you become dilated, you become more like a basketball, you have adverse pathologic remodeling. What we're trying to do, and part of that helps us is to understand is why is that happening, the characterization of the myocardium. And then what are the therapies that might help us to reverse that pathologic process? So how can we favorably remodel the ventricle to get it more of that conical shape to improve efficiency and other things? So we've talked a lot about heart squeeze and systology. I would actually encourage people to think more and more about ventricular dimensions, however you want to go with that, whether that's sphericity indices or about end diastolics or however the case may be. But that's really the importance when we're talking about meaningful change at a myocardial level. I can give anyone with depressed ejection fraction improvement in their EF. I can give them an epi spritzer, right? That's not the best harbinger of outcome, though. I'm not doing that patient any favors. So keep that in mind whenever you're talking about what are we really doing as far as important cardiovascular implications. This is cardiac MR in a patient with overt LV non-compaction. You can appreciate the deep trabeculations and recesses. And once again, just the opportunity, you can just see things so much better. And an important thing for what we do in heart failure is that you can see the right side very well. Get very nice volumetric calculations and highly, highly reproducible. This is when a patient is exposed to gadolinium, so a contrast agent given intravenously to look for areas of dense focality of presumed scar. All it means is that the gadolinium doesn't get out of that area for whatever reason. Presumably, most of the time in physiology, we think it's scar, but it can be other things as well. But it gives you an idea of which pieces of the myocardium are normal and what aspects of the myocardium are abnormal. This is kind of the latest and greatest kind of stuff for what we're doing with cardiac MR, and this is something we're taking advantage of in our institution, is the opportunity to look for scar or changes in the myocardium without giving contrast. So this is called native T1 imaging. And this is a big deal, especially if you have any patients with chronic kidney disease, very diminished GFRs, then you don't want to expose them to gadolinium, right? So this gives you an opportunity to characterize the myocardium very similar to what we would do with a post-contrast T1, so LG-type imaging, without giving them gadolinium. So very exciting, and something we're accruing more and more data. We do this a lot in adults. About 1,100 would be about normal. You can appreciate the different sort of pathologic changes that can be seen that can impact your native T1 values. So this is kind of an up-and-coming opportunity. This is the one that I think is the most important for what we do, is how we looked at the extracellular space. So once again, what do you think really makes the biggest difference in how the size of the heart is described? Is it because of a bunch of cardiomyocytes? No, it's the framework of the heart, right? It's the extracellular space. And the ECV can actually be calculated by MR in a non-invasive way. So you can use a hematocrit. There's an established formula to give you an idea of what the extracellular volume is. And that gives you some ideas about, are there changes in fibrosis burden? Also gives you an idea about edema, inflammation, other things that are important for what we do in heart failure management. But perhaps most importantly is that ECV is a nice alternative to doing the gadolinium kind of based imaging. Gadolinium is great if you have focal areas of change or fibrosis. So say you've had an MI. You have a big anterior wall MI, you'll be able to see late gadolinium enhancement. For diffuse processes, many of what is seen in genetically triggered cardiomyopathies, you'll see no LGE burden. But on postmortem, they'll have diffuse fibrosis everywhere. So their ECVs can be very abnormal, even in the face of a relatively normal native T1 or native or post-contrast LG imaging. So this is just another added piece of the puzzle, leveraging these ECV calculations and how we assess the myocardium. So once again, you can get an idea of how much of the myocardium appears normal, and this is something that you can follow longitudinally. Just you can follow LGE burden longitudinally. Are the therapies that you're offering making a difference in that? Are you plateauing the effects of LGE burden? Are you decreasing the effects of LGE burden? When we talk, the other piece is just briefly about dysrhythmias and potential for arrhythmia burden. I think everyone in the room recognizes, and we've heard about it from other talks, the potential for ventricular and atrial dysrhythmias is a reality in patients with cardiomyopathy and Barth syndrome, whether that's underlying DCM, isolated LVNC, DCM phenotypes. All these different things are subject to dysrhythmia. And many of these can be life-threatening. I can tell you in clinical practice, especially in adult cardiology, typical surveillance may only be done in the setting of symptoms. So if someone comes in and says, well, I'm having pre-syncopal sort of problems, or once a day I'm feeling these flutterings or palpitations, that may dictate the kind of therapy you choose. So maybe you would do a Holter monitor, you might think about doing an EKG. But unfortunately, many of these patients may be asymptomatic, and their initial presentation of dysrhythmia is sudden cardiac arrest. So it's important for us to try and get a better idea on these things. And this would be a conventional approach to what we would do. We might do an EKG on a patient. We might do a Holter monitor on a patient ultimately for 24, 48, 72 hours. Sometimes we'll do event recorders where patients can be monitored longer and longer. But if you think about that, an EKG is just a few seconds in a day out of a year. A Holter monitor is 1 day out of 365. So if you're not having those on a daily basis, the likelihood that you're going to capture something is relatively low. We've tried to become a little more thorough in how we characterize dysrhythmia phenotypes, I guess is what I would characterize this. And there are two opportunities here. One is that you can actually do patches or wearable devices that are much more sustained, that aren't as intrusive to patients as things like Holter monitors. This device in the bottom is called a FACC device, and you can put it on for 7 days. You can wear it in the shower. You can do whatever you usually do. And you can get up to 4 of these, and so you would get 28 days of monitoring. And it's pretty interesting. It's actually essentially real time. Someone is monitoring these devices. And then on the bottom right is a device that we're studying currently in a cohort of LVNC patients. Is called a LINK device, which is an implantable loop recorder. So you put that under the skin. Takes truly about 12 minutes to implant one of these things. It's a sub-Q device that lives just under the scapula, under the clavicle, excuse me. And you can get up to 3 years of continuous arrhythmia monitoring with one of these devices. And interestingly, what we've seen, now we haven't done this specifically in Barth, but we've done it in non-compaction. And in some of our kids, so like 5, 8, 10 years of age, we've actually diagnosed atrial fibrillation. You talk to any pediatric cardiologist in the room and say, we don't see atrial fibrillation. We are. So it's just a matter of, once again, finding stuff often depends on the test that you use to actually look for it and how thorough you are in looking at it. And so we've documented some ventricular tachyarrhythmias as well. So therapeutic strategies. Briefly, heart failure, take away that it's a complex clinical syndrome. It isn't like, when you're in training and you're at the VA and someone comes in 30 pounds up and they're congested. That is only a small modicum of what heart failure is. That's when you give them a bunch of Lasix and pop them out the door, right? That's not really what heart failure is. Heart failure is a complex clinical syndrome. And this is just a very high-level snapshot of what heart failure looks like in reality. So ultimately, you get some sort of myocardial injury, whether that's a genetic trigger, whether it's an anthracycline exposure, whether that's an MI. Ultimately results in a performance fall in in the left ventricle, or it could be right ventricle, or both. And you upregulate the renin-angiotensin-aldosterone system and the sympathetic nervous system, which leads to deleterious findings. Ultimately, you get the things that cause the symptoms, right? You get sodium retention, you get results in edema. But the other side is you get changes at a gene expression level, which you've heard a little bit about throughout the conference, and ultimately results in morbidity and mortality. So what we're trying to do is disrupt some of these axes when we treat patients with heart failure. On the pediatric side, heart failure is increasingly seen as a problem, whether that's a post-op TET patient or whether that's a genetically triggered DCM patient or otherwise. And the important thing you have to remember about kids is they're very different than adults. They tolerate myocardial dysfunction way better than anyone in this room. And you'll come into one of our clinics and someone with an EF of 20% will run past any of you any day of the week. Whereas if you had an EF of 20, you probably wouldn't be sitting here listening to me lecture. So you have to remember the ability to understand recognize and manage pediatric heart failure is a little bit different than what we do in the adult world. And just a quick blurb before I get too far down the path on some of the novel therapies. These are different phenotypes associated with LV and C. So this is from a Lancet paper that we had published. But you can see sort of what we would call a benign form, where in an isolated setting without presence of congenital heart disease, you can see LV and C, but normal wall thickness, normal systolic function. And those patients, for the most part, if they don't have a high arrhythmia burden, have the outcome of the general population. Okay, so that's an important takeaway. You can see it associated with more of a dilated phenotype and then a hypertrophic phenotype. And then we see some other things such as restrictive and then biventricular non-compaction. But what I want you to take away from this is very simple. How we manage this type of heart disease is really dependent on the concomitant phenotype, okay? So a patient comes in and has a dilated phenotype in the setting of LV and C, we treat them with targeted remodeling therapies, ACE inhibition, beta blockers, ARBs, all that sort of business. If they're hypertrophic, we would approach them very much like a hypertroph. So what is your sudden cardiac death risk? Have you had an unexplained sequel event? Do you have non-sustained VT? Because then we're potentially going down an ICD pathway. So just take that away when we talk about management of LV and C, because I didn't want to spend the entire lecture talking about that. This is a slide from 2009, these AHA-ACC heart failure guideline recommendations. And you can appreciate going from left to right is how things become more severe. So on the left are patients who are at risk, and one might argue with genetic triggers, all of those patients in that cohort are at risk, right? So just keep that in mind. And the goal is you're going to try and avoid the bad things if you can. That's kind of the simple takeaway. So don't allow them to become obese. Try and avoid sedentary lifestyle, all the usual sorts of things, no drugs, no alcohol, no smoking if you can. But then you start moving over to the right. So you have stage B, stage C, stage D. Stage B is where you start seeing a decline in systolic function, but people don't really have symptoms of heart failure, okay? It's asymptomatic left ventricular systolic dysfunction. And then when you jump over to stage C, that's when you actually start having symptoms. You're admitted for heart failure, starting having symptoms consistent with New York Heart Association classification of heart failure. And that's when, once again, you're going to try and ramp up some of the therapies that we had started over here in B, okay? And some of the additional changes may include things like aldosterone antagonists and whatnot to try and help. In certain populations, we may use combination drugs such as hydralazines and nitrates. But ultimately, you're trying to avoid going over to this last stage, which is stage D. That's what we're talking about: mechanical circulatory support, transplant, or conservative palliative care, and maybe not doing anything, right? So all of what we try and do at heart failure is trying to restage patients, if you think about it. We're trying to get them back going the other way if we can. And sometimes that's pretty challenging. But the drugs that we use, remember, these are for patients with that systolic problem. So the relaxation, we don't have good therapies, and that may be a bit off into the future. But for the systolic piece, we have pretty good therapies, and so we would try and get everyone on these ACEs and ARBs. And cumulatively, they have a pretty dramatic impact in the adult world on outcome, okay? Especially ACE inhibitors, beta blockers, and then the addition of some targeted therapies such as hydralazine and nitrates. So recently, and just as a brief comment, we recently reported, the question has always been, well, what about in the setting of non-compaction and systolic dysfunction? Do these therapies actually work? Well, they do. We just reported this on a pediatric cohort from our place. We follow lots and lots of non-compaction, probably as many patients as anywhere in the world, I would guess. And the question was, did they really have an effective response? And the answer is they do. Over 2/3 had an improvement in their ejection fraction, and most of them had this favorable remodeling business I was talking about, where the end diastolics actually go from big to small, which is what you want to happen, okay? So, but back to what I was talking about with what are we trying to accomplish? What are the things that are deranged in heart failure? Well, you have a shift in favorable neurohormones and unfavorable neurohormones, and these are what lead to a lot of the pathology. These lists are by no means all comprehensive. But the things that we're kind of fighting are that downstream effect of the RAS activation, SNS activation. And then we have some other favorable neurohormones that actually we try and leverage sometimes in therapy. So BNP being probably the one that's most commonly heard about. So B-type natriuretic peptide or brain natriuretic peptide. It induces vasodilatory responses, helps because it's a natriuretic peptide, helps you to diurese fluid. So you can imagine in the setting of heart failure, having more of this may not be a bad thing, okay? And we use that in forms of certain therapies, things like nasiritide and other synthetic natriuretic peptides. And these are where our current therapies work. So you look at ACE inhibitors, beta blockers, ARBs. Many of them have a favorable effect on the myocardium, on the kidney, and on the vasculature. And ultimately, what we're trying to do is exactly what we talked about, is you go from a normal myocardium, you get over to more of this dilated phenotype. We're trying to go back this other direction. That's what we're trying to accomplish with these therapies. Sometimes we're successful, sometimes we're not. But what we would really like to do is back to, if you think about it in sort of global terms, we'd love to keep patients out of the hospital. We'd love to reduce symptoms. That's the goal of what the FDA usually drives, improve quality of life, those sorts of things. But ideally, we'd love to have drugs that offer lusitropy, so drugs that relax the heart muscle, drugs that have antifibrotic effects, because that scar, back to some of those MR images, are driving a lot of pathology, some of that impaired relaxation that we see in heart failure. And we would love to go from the basketball to the football, right? That's the remodeling aspect that we're trying to accomplish. So the drugs that we currently use, when we talk about ACE or ARBs, really target this pathway. We're trying to disrupt this ultimate vasoconstriction, changes in fibrosis and myocardial hypertrophy. But also, these natriuretic peptides are, as I said, are favorable, right? They have vasodilatory effects, they have natriuretic effects. They're thought to have some anti-inflammatory effects, some favorable remodeling effects. All these sorts of things would be great, but your body inherently degrades these through a neprilysin system, okay? And so if you were to disrupt or perturb this system where you're inhibiting this enzyme and actually could increase the endogenous levels of these natriuretic peptides, kind of makes sense, right, based on what we've been seeing. And so it actually was studied recently, so I just wanted to give you sort of a high-level view of some of the important things in adult heart failure medicine, and this is one of them, the Paradigm trial, which looked at a drug called LCZ696, which is currently now marketed as a drug called Entresto. And it is a combination of an angiotensin receptor blocker, which we heard about as a good thing, plus a neprilysin inhibitor, which is also potentially a good thing. And this has kind of been a blockbuster. Longitudinally, it's hard to know if it's going to make the differences that we thought that it would, but at least in this one randomized clinical trial, Paradigm, there were some major changes. So these patients received standard therapy, so they're on enalapril, 10 milligrams twice a day, versus this new drug, which is now currently called Entresto. And you saw significant changes in multiple clinical endpoints. This one is cardiovascular death and or hospital admission for heart failure, okay? You see clinical significance in all of these, so much so that the study was stopped early. So it was in 27 median months of follow-up, and they decided to stop because the DSMB felt like the data were so compelling that the study could be stopped. And this drug, just to give you a brief intro into our ACC/HA recommendations have recently changed, and you'll see some new things here. This BR, moderate quality of evidence of one or more RCTs, which is what we're talking about here. This drug has had one major clinical trial. But currently, in the past, we would have said either ACE or ARB. We would start with an ACE, and if people are intolerant, we would go to an ARB. Now you have the opportunity, in honor of Dr. Strauss, to get an ARNI. So you can potentially do this angiotensin receptor blocker, neprilysin inhibitor, and which is a pretty big deal for a drug to get changes in guidelines just based on one randomized clinical trial. The other piece, we talk about dilated cardiomyopathy and especially non-compaction as a potential for thromboembolic phenomenon. So dilated cardiomyopathy, based on that image I showed you a few minutes ago, has a potential to develop thrombus. And if that mobilizes, obviously that's the nidus for a stroke. This becomes really dramatic when the ejection fraction is less than 15%. And that's when you start thinking about, should I put them on some kind of therapy? The debate of which kind of therapy is still out there, whether it's aspirin, Coumadin, that sort of thing. But in LVNC, it's a pretty big deal. If you look at patients as a natural history cohort in LVNC, up to 40% of those patients may experience a thromboembolic event. That's a pretty big deal. Some centers prophylactically put patients on systemic anticoagulation. So we haven't done that as aggressively in our kids, but in adults, it's potentially a big deal. And things such as atrial fibrillation and concomitant LV systolic dysfunction play a big part in that. Just a brief bit, we heard about things like ICDs and pacemakers and that sort of business, just a couple of quick slides. This idea of cardiac resynchronization therapy, so we talk about people with heart failure, the ability to conduct electrical activity in an appropriate way through the myocardium is deranged. And sometimes patients will present with a left bundle, and oftentimes it's because of all that scar tissue that I've been showing you. So that means that the part of the heart is electrically activated in a sort of a suboptimal way, if you will. And so what we try and do with cardiac resynchronization therapy is actually use pacemaking of both the right and left ventricles to get the heart sort of back on track. So it's squeezing in more of a synchronous way, if you will. And so the question has always been, does it make a difference? Would it actually work in patients with non-compaction and systolic dysfunction as opposed to just having pure dilated cardiomyopathy alone? And this is important, obviously, for our population with Barth syndrome. And it actually turns out patients with LVNC may respond better. So when you talk about advanced therapies, what I encourage people, first of all, if you have the opportunity, send patients, if you have Barth patients that have cardiomyopathy, encourage them to go to a specialist or someone who's familiar with cardiomyopathy care. But unfortunately, in many pediatric cardiology institutions, we may be going from traditional outpatient oral therapies to high-dose inotropy to transplant, okay? And somehow we miss some of these opportunities for advanced therapeutics in heart failure. So I'd encourage you, or if I can ever be of assistance to anyone, please feel free to email me. But there are lots of opportunities to prevent potentially going down the transplant pathway, and that's a big deal. Once you transplant someone, the clock starts ticking. Those hearts don't last forever, okay? You get a little bit better result if you get transplanted as a neonate, but otherwise, you have about a 90% chance usually of surviving the first year, but then it's quite variable. You may get about 12 to 14 years out of that graft. So keep that in mind. If we can preserve native myocardium, that's always the right answer, if you can keep patients asymptomatic. So in summary, cardiovascular disease and Barth syndrome, there are real growing opportunities to better characterize the burden of cardiac disease in Barth syndrome. I think it's a very exciting time based on some of the tools that I've been telling you about. Earlier recognition of cardiac disease allows for potential to tailor longitudinal surveillance, okay? So let's say that you do have a concern about fibrosis burden, you do have a concern about arrhythmias. How frequently you see those patients and the type of surveillance you use can be modified to fit the individual in front of you, which I think is a pretty big deal. And this idea of deep cardiac phenotyping is really something we're getting more and more into. We talk about genotype, phenotype correlates. We talked a little bit about this meeting, and we talk about it at every disease-based meeting that I go to. And I can tell you that unfortunately it's not the genotype information that's usually missing, it's the phenotype information. So the better job that we can do at phenotype characterization and being uniform in how we do that will really inform future research. Novel diagnostic and management strategies continue to be developed and approved for patients with cardiomyopathy and resultant heart failure. And I think these new treatment options may offer some additional avenues of investigation and potential treatment for our patients with Barth syndrome. You have to remember, as a clinical cardiologist, when someone comes to me, I treat the phenotype in front of me. So those are the things that are going to be available to me. And I think, it's fantastic, all of the discussions we have about different sort of targeted strategies, but in the current era, these are the treatment strategies that exist. And so leverage them to the fullest opportunity, I think, in these patients could make all the difference. So with that, thank you for your time.
Thank you, John, for such a comprehensive review. Time for a few questions.
So first question, actually getting to diagnosis, I think sometimes as adult clinical cardiologists, we see patients and we are so focused on the phenotype that as a physician investigator, I'm even embarrassed myself that I've turned off my brain to these etiologies. So first question, when I see a sporadic young, say 20-something male patient with non-compaction, do I need to evaluate him for Barth's?
It's a great question. I guess this is on. Usually in those patients with non-compaction, we do consider genotyping in those scenarios, and many of the currently available commercial panels would include testing. I think, or if you really had a real question, getting a geneticist involved is not an unreasonable thing as well. We're pretty heavy because most of my population is a heritable population, so I'm not seeing lots of post-MI patients, for example. And this idea of idiopathic cardiomyopathy, I hope continues to fall away. The majority of those patients are genetically triggered. And so there are going to be some underlying patients in there with Barth syndrome, just as other genetically mediated cardiomyopathies. So we've been pretty aggressive in using genetic testing because, one, it informs how we're going to manage the patient. Obviously, if they had Barth, that's going to trigger other referrals. But the other piece, this idea of cascade testing, we get a positive genetic hit in that patient, we're going to be doing first-degree relatives. And we've captured lots of patients, not specific to Barth, but for other types of diagnoses, such as Noonan or sarcomeric mutations, simply by doing that. Patients that were living with disease that were told their symptoms had nothing to do with cardiovascular. And like, oh, your syncopal events were just because you were brushing your hair, don't worry about it. And actually turned out they had non-sustained VT. So that's kind of how we approach those patients, that we would consider genetic testing, and that would capture a fair amount of that opportunity.
So I wanted to ask you, this damage that you can record by MRI, so do you see more of it in contractile parts of the heart or in these rhythmogenic types of the heart? And where's, in regards to this also, so there are ways to make gadolinium targeted to mitochondria, for instance. Mm-hmm. And then you will see whether it coincides with the concentration of mitochondria in the heart.
Absolutely true. Those are great questions. I would say, just as you heard about, I think it was from Colin's talk, this idea that there's no Mr. Average kind of a thing. That's probably true for cardiomyopathy as well, is that we used to think, for example, like in Duchenne, there were typical focalities of LG and those sorts of things. But when we look with these newer technologies, it actually turns out it's much more diffuse. And you can see areas exactly as you're talking about in more of in contractile regions. And when you talk about, I think that's the advantage of doing a more comprehensive cardiac MR approach, is it's back to this idea, we really spend a lot of time talking about contractile apparatus. For us, it's the sarcomere, obviously, with mitochondrial function driving so much of what we do in heart failure in general, mitochondrial dysfunction. The idea of not only being able to characterize that MR, but looking at the extracellular space is probably even a bigger part of what we do. I do like the idea, I didn't go into this to sort of exploratory MR technologies, but exactly what you're talking about is absolutely true. So combining metabolomic imaging such as PET and MR exists in the current era. Not many centers have access to that. As you heard yesterday, there may be some question whether PET actually makes a difference. I think part of that's probably timing in the disease. Do you have evidence of that? Do you have an overt cardiomyopathy phenotype enough to detect abnormalities in PET? But you're absolutely right, is that you could do very organelle-targeted imaging, which would be exciting and part of what we're very interested in, because you talk about the myocardial energetic substrates are a big deal, and they're actually common across many types of heart failure. When you go from changing from free fatty acid to more glucose or carbohydrate-based metabolism, that's actually quite common in adult post-MI heart failure. So there are a lot of commonalities that could be learned.
Thank you. Can I just ask one brief
Yes,
wrap-up question, which is how long does one of your native MRI studies take to actually perform, say, in a child?
Great question. So if you did no contrast, you can, this is a fantastic question. He's a ploy for me here for a plug. We're actually doing a study on this right now. We're seeing, back to this idea of chemotherapeutic-induced cardiotoxicity, how can we better characterize myocardium without exposing patients to contrast? We can do it in about 8 minutes. Now, a real MR where you get gadolinium and you get the full sequencing and the whole deal is about 40, 45 minutes optimally. But this very limited sequence with no contrast exposure you can do in under 10 minutes and get a lot of the information we're talking about.
That's an exciting concept, I think. Is it a very brief question? No, not brief.
We'll talk later.
Perhaps privately, yeah. Thank you very much for such a lovely review.